Emergency rooms in Massachusetts have been pushed to their limits and beyond several times over the course of the pandemic. And as we head into our third winter with COVID reduced, but still here, we're already seeing hospitals more overrun than ever. The Boston Globe reports on absurd wait times for a bed. 8 hours in one case, even more in others, and a jump in patients leaving without the care they need, citing a recent national study which found the rate of such cases nearly doubled from 1% to about 2% between 2017 and the end of 2021, putting patients at risk for even more severe illness. One hospital official who's worked in emergency medicine for nearly 30 years told the Globe these conditions are unprecedented in his career. That would be Dr. Michael VanRooyen. He's chief of enterprise emergency medicine at Mass General Brigham, where 6% of patients coming for emergency care left without being seen over the last 4 months. He's also the director of the Harvard Humanitarian Initiative at Harvard University and a professor of emergency medicine at Harvard Medical School. Dr. Laura Burke is an assistant professor of emergency medicine at Harvard Medical School and an attending emergency physician at Beth Israel Deaconess. Dr. John Santiago is an emergency physician at Boston Medical Center, as well as, of course, a state representative from Boston. Doctor, thank you all three for being here. I really appreciate it.
Great to be here.
Dr. Burke, can I start with you? I'm sure you read Kay Lazar's piece in the Boston Globe. You heard a little bit of what I said a minute ago. Are things any different at your place than they are at Mass General Brigham?
I think one of the aspects of this crisis is that it's fairly universal. It's not just in Boston. It's not at any particular hospital in Boston. It's not unique to Massachusetts. It's really something we're seeing nationwide when we talk to our colleagues. And this is something that people are surprised by, but that our leaders in the field have been warning about for years, even decades, in fact, that our healthcare economics do not incentivize being prepared for a crisis like this. And we, too, are experiencing crowding. We found ways to try and mitigate, but we are also experiencing the staffing shortages and crowding that are plaguing every ED in this emergency department in the state.
Dr. Burke, do you know the percentage of people who come to the emergency room who leave as per what I was just describing a minute ago without getting care?
I don't know the number for the last 4 months. It really varies from shift to shift. You know, on the busiest days, like today's Monday, Mondays are predictably busy and crowding is high. I'm sure it'll be higher than on the Sunday overnight shift. But what the specific percentage is that's equivalent, I don't know that off the top of my head.
Dr. Santiago, is this emergency room condition, crisis, whatever you want to call it, is it universal? Is it happening at your place too?
It's absolutely universal, Jim. Let me just say, I'm sure I speak for the two physicians on this call as well. I mean, really being an ER doctor is really one of the privileges of my life. And I say that emergency medicine is an effective lens into the community. When there's an economic crisis or a surge in violence, you know, we take care of that. And what we see right now with the ED crowding, ED boarding issue, I mean, that's reflecting our health system. And it's just frankly it's not working.
Can you describe what boarding is for lay people, please, Dr. Santiago?
So the article that you were referring to talks about the phenomenon left without being seen. Those are folks who are in the emergency department waiting room who leave prior to being evaluated by a physician. Boarding refers to when a decision is made that the patient needs to be admitted to the hospital. And as soon as that decision is made, the clock starts. So typically you want to get someone into bed within 4 hours. But what we've seen over the past couple of years, for a very long time now, that people will stay in the emergency department for hours upon hours, I mean, up to 24 hours. And particularly in the setting of this mental health substance use crisis that we're seeing, I know I speak for my colleagues here, I mean, it's unprecedented trying to have someone with active mental health issues in the hallway of a bed, in the hallway of a hospital.
Dr. VanRooyen, why is this happening? I mean, Dr. Burke said it's been a long time coming, so it shouldn't be a surprise. But what caused this to explode right now?
Actually, one of the main, well, first of all, thank you for having us on and kind of demystifying this issue because it's a little bit complicated. One of the major issues that we see are that hospitals are so full and the length of stay for admitted patients are 1 or 2 days more than they ever have been before, which means that they can't get patients out to post-acute beds, to rehab beds, et cetera, which means those patients back up in the emergency department to those boarding patients that really become extreme. At Mass General, we've had up to 99 boarded patients in the emergency department waiting to be admitted.
Is that in part, Dr. VanRooyen, because so many people we read about and spoke to and heard about avoided care during the pandemic for fear that they'd get COVID if they went to a medical facility? Is that backup part of the problem?
I think no. I think the real reason is that staffing shortages in, say, rehab beds or rehab facilities or nursing homes make it very difficult to get patients out of the hospital and to those facilities, which means that patients are waiting days to get out of the hospital, such that we are backing up in the emergency department.
You know, Dr. Burke, when I read a number in the story in the Globe, I thought it was a typo, and I had one of my coworkers check. The Mass Health and Hospital Association said there are 19,000 vacant positions in hospitals across the state, and we dug a little deeper, and that's roughly 17% across the board. Obviously a little higher in some positions, a little lower. To me, that is unimaginably horrible. Is that at the core of the problem at your place?
It varies. I work in Boston. I work at our community hospitals. Some geographic areas are able to recruit better, but that is also universal. We're all hurting for nurses and other staff members. There's just a shortage of the people we need to staff the inpatient beds, to staff the emergency departments. And if we don't have nurses in particular, we can't get patients to inpatient units, and we can't take care of people in the ED.
You know, Dr. Santiago, one of the things, whether the number is it's up to 2% nationally, 6%, I know it's higher on certain days at certain hospitals in Massachusetts, the patients who leave. Starting with you, Dr. Santiago, but then I'll talk to all three of you. Do you have any idea what the consequences for that person who does leave are, what they do? Do they go to urgent care? Do they just go home? Do they die? Do they get worse? Starting with you, Dr. Santiago, do we know or no?
What we do know is that there are negative consequences associated with ED boarding. We know that morbidity, mortality rises. We know that burnout increases as well, and we know that it's more expensive. Now, with respect to left without being seen, people may often think that, oh, that person didn't need to wait. Their condition wasn't as serious, their symptoms weren't as bad, therefore they decided to leave. But what we've seen in the literature, that's not true. Folks are just as sick, so if they're having chest pain, they come to the emergency department, they very well could be having some significant heart attack that's going to require some acute intervention. If their right arm is feeling kind of numb, they might indeed be having a stroke, but they have to leave because they have to take care of a sibling or go to work, and that has some negative health consequences without question.
Dr. VanRooyen, have you been able to track it all? I know it's sort of odd to say, what happens to those who leave, because if you knew that much, they probably wouldn't have left. But do you have any idea about what happens to those, whatever the percentage is, that leave?
So I'll agree with Dr. Santiago. It's fairly well known that those patients suffer from the same rates of heart attacks, strokes, and severe illness than those that come into the emergency department. We have a callback system where we check on patients to make sure that they got care, but frankly, we don't know the complication rate. I think it's, one thing that we do, because we have such extreme crowding, we try to fit everybody in, because I'd rather see people, even in a suboptimal setting, than to have them sit in a waiting room when they're unknown.
Suboptimal meaning you may have to ask them questions where somebody else, another patient, is sitting just feet away, and there may be a privacy concern. It may be in an unorthodox physical setting. Is that the kind of thing you're talking about, Dr. VanRooyen?
That's exactly right. We have people in hallway beds, in sitting areas, in every place in the emergency department. But again, as a provider, I'd far rather have that, even however challenging it is, than not know those patients that are coming in and leaving without being seen.
Dr. Burke, as a consumer of what the three of you do, rather than a provider like you, what is equally terrifying to me, the wait, the people who just leave without getting care, are the people who read the story or hear in their neighborhood that you got to wait for X number of hours till you either get seen or get a bed or whatever, who say, I'm not going to even go there to begin with. I'm just not going to get care. That's a serious issue that I guess is unquantifiable, but obviously there. No, Dr. Burke?
That is absolutely a concern, because it's not the job of the lay public to judge their own emergencies. If they feel like they need emergency care, they should come in. And we know this from the early pandemic when people did delay care. We saw that when people did come in with strokes, they were more severe. We know that there was excess mortality that was not explained by COVID alone. And we think that this care avoidance was a key driver of this. We still want people to come in, and we will do our best to get them seen and get them the care they need. It's heartbreaking to have to deal with crowding and have to work in these suboptimal conditions, because we all want better for our patients.
Can we talk for a minute about possible fixes? Dr. Santiago, or in this case, Representative Santiago, I know in the economic development bill that finally made it out of the legislature, it's not your fault, but whatever it is, that finally made it to Governor Baker's desk that he hasn't signed yet, but I assume he will. $350 million, I think, is the number out of the $3.8 billion that's in there for fiscally strained hospitals. I don't even know what a fiscally strained hospital is. But will that allay some of this problem, or is it targeted to other kinds of things?
It's really just a drop in the bucket, Jim. I mean, as the doctors were saying, my colleagues on this call, I mean, this issue has been going on for quite some time, and I'm glad that article in the Globe come out and that you're highlighting this issue, but it really needs to be addressed robustly and aggressively. As Dr. Burke said, there really is a misalignment of healthcare incentives that's really driving this, in conjunction with the insufficient healthcare capacity, whether it's the labor shortage, whether it's the increase in mental health substance use. There are a whole host of things that need to happen right now. The $350 million, that's a drop. It's an important one, no less, particularly in the setting that we're of COVID and coming out of COVID. But also, we need to do so much more. We just passed a significant omnibus mental health bill to really hopefully address some of those labor shortages as well.
So, Dr. VanRooyen, is there, other than outside help like dollars, is there something within institutions that, I assume you're doing everything you can, but what can be done to try to address this within a hospital or a hospital network?
Sure. So the first step is that having the hospital and the hospital network overall understand that this is not an emergency department problem. This is actually, our emergency departments, as busy as they are, without boarding, could take care of our patients. We're designed for it. We serve our patients and we serve our communities. So this is a hospital and a system-wide issue. So the first is the recognition. Secondly is actually distribution of patients around the system. So what we call load leveling between the academic and the community sites. Then having novel solutions like building home hospital resources or telemedicine resources, so we can actually find ways to move patients out of the emergency department into alternative settings.
So based on what you said, Dr. VanRooyen, if we were to speak in 6 months, is your estimation that the problem would be less severe or no?
Oh, no. I think that, one of the challenges that the hospitals are so full, and the labor shortages on the other side of it are so severe still, that I don't anticipate this getting better. And so we need to come up with every available solution to mitigate this issue. And there are, dozens of different solutions that we need to take on. But the first is the recognition by hospitals and by the overall health system that this is not an ED problem, it's a hospital problem.
Are you saying that because there's not that recognition?
Yes, I think that actually it's difficult for people who are not or outside of the walls of the emergency department to really understand that the boarding issue and the crowding issue is really an institutional issue. And I have colleagues that are working very hard in the institutions to solve these problems too. So it's not like they don't necessarily recognize it, but it is a huge issue, and we need everybody to understand it and to help.
I saw both of you nodding your heads in agreement with what Dr. VanRooyen said. Last question for you, Dr. Burke. So someone's watching tonight and hears what you're saying and says 3 days from now when they have a health crisis or problem, I'm not sure I'm going to go do this. I don't want to sit there forever and not get care. What do you say to that person in advance?
I think one option would be to talk to your physician to help triage where you should go for your care. Certainly, if you think you're having a medical emergency, I still advise going to the emergency department. We will find a way. Certainly the wait is longer, but if you think you're having an emergency, do not delay care. If you're not sure and you wanted to talk to your physician, there are other ways that in places that care could be handled, but I would not try and go it alone and try and judge for yourself. I would talk to a qualified healthcare professional to get the care that you need and to help walk you through the options that exist.
Dr. Burke, Dr. Santiago, Dr. VanRooyen, thanks for your time tonight, and much more importantly, thanks for what you do during the days and nights at work. Thank you all. Really appreciate it.
Yes, sir.
Thank you very much.